the onus of proof that something works, something that's more expensive or more invasive, the onus of proof is on you to show us that it works in a randomized controlled trial, because that is the way that we have to prove things work. I mean, there were, I think, more than 30 observational studies showing that HRT associated with better outcomes, and one randomized control trial reversed it all.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. This is episode 101. For those of you who haven't listened to our centennial episode, which was released on the 5-year anniversary of my nonprofit startup, makeadent.org, last week on September 16th, it was with Professor Valentin Fuster. I recommend for all of us to listen. Some incredible pearls of wisdom there by a man who needs no introduction. And with that preamble, I have a gentleman here with me who also needs an introduction. He's very well known in the cardiology community and beyond. I have with me the honor of Dr. Mandrola's presence, John Mandrola, and I've had the privilege of co-authoring a JAMA Network paper with him, which came out about 2 years ago, on a topic which he's passionate about, which is constructing trial design properly so that we can answer questions meaningfully. Just to introduce Dr. Mandrola, not that he needs any introduction. He's a clinical cardiac electrophysiologist in Kentucky. Has a busy clinical practice. He's the host of Medscape's theheart.org podcast, which we all know. He has a space of his own through a platform called Sensible Medicine, which if any of you have not subscribed, I highly recommend that you subscribe to it. You'll get these updates on email whenever he has something written up, which is very informative for clinicians on in the trenches and at the bedside taking care of patients with complex comorbidities. And he's a former Indiana man. So, with that introduction, Dr. Mandrola, welcome on the show, and thank you so much for doing this for us.
Thanks so much for having me. It's an amazing honor to follow Professor Fuster. I mean, that's crazy, but so thank you.
No, it's the pleasure is all ours to have you. And I'm gonna begin by asking you a little bit about your journey into where you're at now. Early life, what inspired you to lead a career in medicine, and then what inspired you to be a cardiologist? I mean, you have all your training at Indiana University, and at the time you trained some pretty famous stalwarts in our field were at IU. So let's start there.
Yeah, I grew up, thanks for asking. I grew up in a suburb of Hartford, Connecticut, and just on the Massachusetts-Connecticut border, a little small working class town. And I was just kind of a regular student. And really, I was inspired to go into medicine because my guidance counselor told me that I wasn't smart enough to be a doctor. And he said that I told him that I wanted to go to medical school and become a doctor. And he said, you need a different plan because you're not smart enough. And then that kind of inspired me. And when people tell me I can't do something, I always feel inspired. And really, when I went to college in New York State, a place called Hobart College. And I really buckled down and I started studying. And I found that, well, crap, if you study, these tests really aren't so hard. And I did well there and went back home to medical school to UConn, University of Connecticut. But the thing is, Ankur, was that this was the heyday of modern cardiology. We were medical students and rotating at Hartford Hospital and St. Francis Hospital. And and this was the era of thrombolytic therapy. We just could start doing things for people with MI. I used to escape away to the CCUs and hang out with the cardiology fellows there. And I really just got so interested in cardiology because it was such a booming field in that time. And then I decided that I really wanted to come to the Midwest. I needed to go away from the East Coast. All my friends stayed there. I just thought this was sometime in my life that I could do something and go away. And I decided on Indiana University, and I felt like the best way to get to a place with that many famous people was to do residency at Indiana and really work hard there and get in. And so that's what happened. And then, gosh, during that time, I mean, EP came into being, right? So that was the era where we started doing SVT ablation. The folks who taught me, William Miles, who's at Florida now, and Larry Klein, who's in private practice in Indianapolis. I mean, they had just gone to Sonny Jackman's lab to learn how to do SVT when I was a resident. And so when I joined EP, everybody was learning together. SVT cases were like 7 hours. And also, this was the era when defibrillators started moving from the abdomen to the chest. So it was really just an amazing time and it was all pure luck. I just happened onto these things. And then when the job opened up here in Louisville, it was a great job. And I took a private practice job here, and I've been at the same hospital with some of the same people for 26 years. And so it's been great.
Yeah. Was there any particular moment in medical school that inspired you for a career in internal medicine, followed by cardiovascular diseases, or was it just the gravitas of Indiana University and the people there that was an obvious choice for you?
In medical school, I remember cardiologists come in. I remember being on rotation as a medical student, and I remember cardiologists coming down to the ER and just taking over these situations and being, it just looked like such a cool field. And basically they were just giving thrombolytic therapy and then taking patients to the CCU. And I was just so moved by that I decided first that I wanted to be a cardiologist, and then internal medicine was the route there. And my dad and I got into a station wagon, and we just drove. I think it was like 10 days. We drove across the country, and every day I would interview at a different place, like Iowa and Minnesota and Chicago and Indianapolis and Ohio State, all those places, and come back to the hotel and write letters, thank you letters to the residency program, and then that's really how it happened. And then when I was in Indiana, it was really a difficult decision between PCI and EP, because remember, that was also the time that we started doing acute PCI rather than thrombolytic therapy. So there was that transition in interventional, and also the interventional life was really amazing because you could stop MIs with acute PCI. And I did some of those as a fellow. But I just decided that I really enjoyed the electrical aspects better, and it was more fun. And so I chose EP, and it's been a great field. It is a great field. I love it.
No, thank you for that background. Was at the time you were then deciding to take on a job, did you ever consider remaining in academia, given the background with IU and with University of Connecticut?
Yes, I did. At the time it was like a fork in the path. It was like, should I stay in academics? Should I go into private practice? And really, I decided on private practice because I really just enjoyed taking care of patients and doing ablation and doing that. And I felt like that was what I wanted to do. And it really wasn't until 10 years into my career in private practice that I started delving into academics and writing. And now I do some academics, but I don't regret it. It was a consideration though, but I really enjoyed taking care of people and being a doctor. And that's what I do.
That's what you went to medical school for. So
That's what I thought.
I agree. I mean, I think a lot of us, that's our calling is to take care of patients, and that's what drives us. Sort of making those decisions that you hope would change lives for the better for the communities that you serve. That drives you to a career in medicine. When did podcasting happen for you? Because you said that it took you about 10 years to start writing, or maybe putting pen to paper to write thoughts, which you do such an eloquent job. How did podcasting happen?
Yeah, so for 10 years, all I did was practice medicine every third night call and general call. It really worked hard. Didn't really think too much of anything. And about 10 years into practice, around the time that the blog started happening, blogosphere, remember Mommy Blog started it. And I one of the teenagers that was friends with my daughter said, John, you can write on the internet and sign up and have a blog. So I started this blog. Really, Wes Fisher, electrophysiologist in Chicago, was one of the first ones, and I started reading his blog, and I thought, this is great. And so that's what I started. I started just writing, and I had no background in writing. I'd never written anything other than what we did in college, and I didn't know how to write, and just started doing it. And it got a little bit of traction amongst some journalists, and I got asked to write these blogs for the heart.org at the time. And it was whenever you want, once a month. And then I started writing more regularly for the heart.org. And about the time that Malcolm Gladwell started podcasting, maybe 8 years ago, my editor said, John, she said, young people are getting more and more of their content by listening, and you should start a podcast. And I was really resistant. I said, no way. I don't want to do it. I'm a writer. I had read all of these writing books, like literally maybe 10 writing books about and studied writing everywhere and just tried to get better at that. And then podcasting started. When we first started, it was crazy. I had a little iPhone thing, and it was a video and audio. And it was so painful with that video. And then we just went to audio. And then that's how it started. And then podcasting, I started listening to podcasts, and everybody's listening to podcasts. AirPods came to be, and now podcast as a forum, as a I guess as a device, I mean, it's just taken off. And so that's how it got started. My editor said, you should do this. And I said, no. And she said, just try it. And we tried it, and it just slowly and gradually took off.
Yeah, no, that's exciting to learn the natural progression of you being a writer and then being a podcaster. How long has it been since you've been doing the Medscapes podcast?
I know this because Facebook brought up an early memory, like 11 years with the heart.org. And then I think the podcast started, I suspect it's 6 years ago. It's kind of scary because I would be really frightened to look back at some of the early podcasts, because they were probably so bad. And now I have a microphone, and I have I sort of have a template. It is actually writing, because I transcribed a podcast on Friday, and it comes out. I start writing on Wednesday, and I really write the script for it. I don't follow the script exactly, but I start writing on Wednesday, looking at the week's studies, and ends up being about 2,500 words, like a 25 minute podcast is about 2,500 words. So it is actually writing, although it's spoken rather than on paper.
Mm-hmm. And so, when you are preparing for an episode, what does that look like for you? I mean, in terms of how do you fit that, for the budding podcasters out there, how would you describe that journey or, that preparation, given you are also a busy clinician taking care of patients?
Yeah. So my workflow, I've always, from medical school on, I've always been a morning person. My brain works better in the morning. So I get up early every day. I go to bed early and I get up early, and I do my best thinking and writing in the morning before work. And so I start a couple hours before I go to work, and the journals have a regular schedule of when they publish. As a journalist, I get some of them a little earlier so I can look at that. It's easiest during meetings like ACC, AHA, ESC. It's much easier because there's 20 or 30 studies in the matter of days. During the week, I start looking at the major journals and picking out important studies to think about and start writing around. Really can't start much before Wednesday because really that's when you have to have the studies come out. And so I try and pick interesting studies that are in cardiology, but also teach other lessons. Observational studies that are confounded, or randomized trials that have this weakness or that weakness or this strength or that strength, and try and pick out interesting themes, and sometimes even delve a little bit outside of cardiology into general medicine kind of things.
Yeah, so as someone who scans the studies that are coming out on a weekly basis, how do you make the determination of? Obviously, it needs to pique your interest. Goes without saying. But how do you determine the importance of one study over the other? Because there's a lot that comes out on a weekly basis, and sometimes you'll find gems which are in journals which are not as quote unquote popular, even though I not like to associate that word with science. But it's sort of you could only scan as much. So the question is, what are some of the go-to journals that you would scan, and what are some of the determining factors for you to pick up studies that you want to pick up?
That's a tough one. I would say that, of course, you look at the big ones, right? So I look at New England, JAMA, JAMA Internal Medicine, JAMA Internal Medicine, all really full of gems because Rita Redberg has always had a less is more approach, and I've always loved that. Also, Jack and European Heart, and in my journals like Jackie P and Europace and Heart Rhythm. But obviously you pick the big ones, right? So if a big drug trial comes out or a big device trial comes out, something that's going to move the field, you cover that because it's a big study. But then I try and find things that I think are interesting from a bedside clinician standpoint. And like you said, not always are they big studies. And then so that's one niche. And the other niche I would say is that studies that have some critical appraisal lesson, like a problem with a control group, or a problem with loss to follow-up, or something like that statistical significance is barely met, and all of these kinds of topics. And to be honest, I'm still learning to interpret these trials. I had no idea how complex it was when I first started. And then that's just the interpretation of the trial as written. But then even the other thing that I think that maybe I can offer with 26 years of experience is a little bit on how to translate evidence from trials to the bedside. And here in my world, one of the big issues that comes up is that here in Louisville, Kentucky, which is a medium-sized city, we see a lot of older patients with comorbidities and frailty, and trials have so few patients like that. And so evidence translation is another reason why I would pick a study. But the other thing I'd say about picking studies is that when you do this every week, and you pick 4 or 5 studies every week, even if you miss one, it's highly likely that a month later or 2 months later or 3 months later, another similar study will come out and that topic will come up.
Yeah. So that actually is a good segue for me to ask you about, your stance as a practicing clinician, as a cardiologist, as a cardiac electrophysiologist, of a medical conservationalist. And that is, something which you've ascribed that title to yourself, having read your writings on sensible medicine and your blogs on Medscape, and also some of the papers that you pick, which would, studies that you pick, which would summarize conclusions which aren't necessarily representative of what the data have shown. One of the fascinating pieces on sensible medicine, and I think for those of you who are listening who want to then actually look that piece up from Dr. Mandrola on Substack, would be the 4 big studies that you picked from the 4 big journals that you critiqued, which were, like you said, reputable, big hitters in the New England Journal and JAMA Internal Medicine. And, I would agree, JAMA Internal Medicine has a lot of gems because it sort of is the less is more theme from Dr. Redberg. There are, so my question to you is, how did you get there? That's question 1. And question 2 is, there are critics to this thought and this stance of yours in the community, who have been vocal, who are vocal at the medical meetings, who have been vocal, even on social media. How do you, so first of all, how did you get there? And second is, how do you react, maybe is a strong word, but how would you respond to some of the detractors of your stance? Still, giving them the respect that they deserve, because there should be disagreement, which I think is healthy, but that should not be transmuted into disrespect, which unfortunately it does get transmuted into disrespect, but it should not. And I'll stop here and I'll have you answer this question.
I think the way I got to this medically conservative approach is that also has to do with when I came into cardiology. So when I started in the CCUs as a student, this was at the time when VT and VF and PVCs heralded real bad trouble in CCU, and so there was a strong movement to suppress ventricular ectopy in post-MI patients, and we had drugs that did it. And of course, we all know what happened with the CAS trial. So for a decade, the therapeutic fashion, the expert opinion, the standard of care was to suppress ventricular ectopy because observational studies had shown that ventricular ectopy associates with higher risk of sudden death. And we were wrong. We were killing people. Remember, the number needed to kill in the CAS trial was 29. So for every 29 patients we treated with the standard of care, we were killing patients. And so that was number one. And then the second thing is when I went to Indiana and I had an outpatient clinic at the then Wishart Hospital, the county hospital, we were using hormone replacement therapy in postmenopausal women because we believed observational studies had shown that it associated with lower cardiovascular outcomes. And then when the Women's Health Initiative, the WHI study comes out, we find that actual standard of care and expert opinion was wrong, and we were harming patients. And so I sort of came into cardiology and these two huge things were just completely reversed. And we take it for granted now because they're historical. And so I had this always had this bent that, I wasn't sure of all the things that we were doing. And so I had this sort of Bayesian prior that we're probably more sure of things than we should be. And then, I became friends with Andrew Foy and Vinay and Adam, and we got together and decided to write this because sometimes people, when we wrote these sort of contrarian kind of pieces saying we all should reassess this, and we should prove this, that we sort of got labeled as nihilists and cynics, like we don't believe in things, and this is absolutely not true. And that's where we sort of came up with that medically conservative piece. It begins by saying that we're not nihilists. We believe in many of the things that have happened in medicine, and I mean in cardiology have been amazing. It's a great time to be a patient. But so I think medical reversals and the things that I experienced in my career was a large reason for that. And the second part of your question is, how would I respond to people? I would say what my response would be is that I appreciate the gains that have been made. I mean, in the EP lab now is much better. So technological improvements have been great, but my response to the movers and to the innovators would be that the onus of proof that something works, something that's more expensive or more invasive, the onus of proof is on you to show us that it works in a randomized controlled trial, because that is the way that we have to prove things work. I mean, there were, I think, more than 30 observational studies showing that HRT associated with better outcomes, and one randomized control trial reversed it all. So we're not nihilists. We just believe that things need to be proven in trials before they're accepted over the standard of care.
Yes, and so as a follow-up question to that answer is. And this sort of also dabbles into your recent piece on sensible medicine about, what you perceive is wrong with journals and with investigators. And it's a poignant piece because it takes a poignant stance, and that is that, for better or for worse, a lot of our studies are now being funded by, big pharma, big device, big what have you. And so there is a vested interest, and obviously the investigators and the authors and the co-authors are mandated to disclose that when they're publishing or when they're presenting. And then you have these drug or device trials, which keep showing us benefit. All of which is, it's all great innovation. Compared with where we were even 5 years ago with, guideline-directed medical therapy for heart failure with reduced ejection fraction, we now have 4 drugs, and that's all good. The question becomes: at what point is good enough? As in, at what point? Maybe this is a philosophical question as well, and that is that what are we really chasing? Because we know immortality is not a thing. We have to die. All of us have to die. Is the point? And cardiology has become fairly advanced. That I'm sure in your practice as well, where we're treating octogenarians and nonagenarians, and that's fantastic. The question is at what point do you say, okay, enough is enough, and we have to stop? Because the drugs and the device with the big pharma and the big industry are going to keep coming.
Yeah, it is a philosophical question, and I like to say that whenever there are young people around, I think the challenge of my generation in the 1990s was having enough to do. Having PCI, having devices, having ablation. The challenge of the current physicians coming into practice, I think, is not having things to do, is whether we should be doing it. This is the question that comes up in my practice all the time. I'm always having discussions with my colleagues about whether we should do this, not whether we can. Of course, we can take people to the lab and ablate their left atrium. Of course, we can, put a device in. But should we? And this is where that challenge has been made. We've actually made that a challenge, right? Because of the innovation, and so it's like this. It's this progress has put us into a place where patients don't die of things that they used to die of, and now they grow older with more comorbidities. And that's a lot of the medical conservative piece is would a person with, would a person, if presented the data in a neutral way, would they choose to have that? Would they choose to pay this much money for an SGLT2 inhibitor in heart failure with preserved ejection fraction, knowing that it reduces an endpoint of heart failure hospitalizations, but heart failure hospitalizations is only about 1/5 of the total hospitalizations. And so that whole problem of incremental benefit has been created by some of the success. And so part of the medical conservative approach is to sort of evaluate these new innovations as a value proposition and present it to patients who have their own preferences, and there are minimizers and there are maximizers, and it's sort of our job to frame that. But part of framing that is being able to interpret the studies and get past the positive spin. And that's one of the goals that I have in my writing, is just to try and help translate and help teach translation of these trials and evidence. And there's nothing nefarious about what's going on. It's just we're coming up against the fact that, like you point out, humans have we have an expiration date, and it's become very difficult to innovate further on top of where we're already at.
Yes, I mean, I think just to bring home that point is, with heart failure and readmissions remain a vexing problem, and part of the issue is that the systems where we work at are obviously tracking all these readmissions and want the readmissions to reduce to avoid penalties from payers, and I get that is fine. Which begs to the question that we need to innovate, but maybe we need to innovate not in intervention, whether it's drug or device, but in how we take care of patients or processes of care, or in our policies. Because like a typical heart failure patient with reduced ejection fraction, those 4 drugs are very financially toxic. I mean, there was a recent JACC piece on this as well, and you add to that transcatheter edge-to-edge repair, for functional microregurgitation. And you add to that some of the new innovations which are happening in the interatrial device space to reduce the left atrial pressure. I mean, that is one patient which is very expensive, to the healthcare system. And as a cardiologist at the bedside, I'm not even sure how many meaningful years of life we're adding on. I mean, that is what I think. Philosophically, it has become a vexing question for me.
I totally agree with you. And here's one of my tensions. One of my tensions is that you take something like transcatheter edge-to-edge repair. I take something like that, and there's this minimal. Maybe not. Just take something that has a minimal benefit, maybe a statistically real benefit in that trial with carefully selected patients in the trial environment. Let's say something is beneficial, but it's very expensive, and the average effect is that it's positive, or even if the average effect is null, that a good example is the VA ECMO trial at ESC, and it was a negative trial, non-significant results. But you take these innovations, and they may not work great on average, and they may not be high-value propositions on average, but there probably are selected patients that, if it was carefully used in the right patient, that it might be beneficial. And so I'm not nihilistic about it, but this idea of always blasting every heart failure patient with 4 drugs. Sometimes I wonder whether the ability to take 4 drugs is just a marker for a marker for a good prognosis. They're going to do well. I just think that this is what I do on a day-to-day basis as a clinician, is I try and take evidence and tailor it to the patient. And there are times when expensive therapies, invasive therapies are beneficial. And I guess my favorite thing in all of EP, and it used to be one of the most boring things, but my favorite thing is a pacemaker for third-degree heart block, because it's the purest of medicine, right? A patient comes in, and it's like PCI of a STEMI. Patient comes in, they're sick, they're dying even, and you do a 1-hour procedure and they leave the hospital, and it's so pure. But that's increasingly rare, because now we have these incremental therapies.
Yes, I mean, I think when these innovations happened at the time that they did, for example, the pacemaker, or for example, the primary PCI for STEMI, those were like real wins and have revolutionized how we take care of patients. I'd like to say that, for aortic valve stenosis, transcatheter therapies fall under the same rubric for me, as well. Although, again, philosophically, I at times wonder, if there would be more innovation for rheumatic heart disease in the developing world versus us putting these valves in nonagenarians. I think just thinking philosophically from a global perspective. And I think economy, unfortunately, drives a lot of those decisions as to where, industry wants to, put money, because, that is the economic / business end of things. But where, how far, with regard to how far we've come, both in electrophysiology or interventional cardiology, I should say procedural cardiology, because heart failure is slowly following where EP and intervention went. Where do you see us going? Like, where do you see cardiology going? Because I genuinely feel we are at the other end of the spectrum now, where it's just too much. That's what I personally feel.
I don't know. I'm not sure about that. I think, yes, we're. I think there's something to that, but maybe I'm naive about structural, but I mean, I see us making big gains in structural cardiology with valves. I mean, just the idea that a patient can have an aortic valve replacement through the leg and go home the next day is pretty amazing. And then, and I totally agree with you in rheumatic disease. And one of the reasons why I think it's right is because rheumatic patients are sicker and younger, so there's more to gain. So I see cardiology innovating significantly in the structural field. I'd be worried if I was a heart surgeon right now. So that's one gain. I think that I'm very excited about conduction system pacing in my field, because now we can pace the ventricle without creating dysynchrony. We're trying to show, and we may show, that a single lead can replace what a CRT can do. And as far as young people coming into the field, there's a lot to learn in these areas that you can really help people. But I would still get back to your idea about processes and how best to apply the therapies that we have now. And I would argue, my medically conservative brain would argue, that when we implement policies, they need to be implemented in an evidence-based way. And I think that we could randomize much more than we do in terms of processes. And we have a lot of ideas that if something is good intentioned, then we should just do it, like the hospital readmission penalty policy. I mean, to me, that just teaches us so much about unintended consequences and the importance of randomization before. So I think I see a lot of benefit in valvular heart disease. I see a lot in my field of pacing, and I think there'll be a lot of developments in processes of care. My wife is a palliative care physician, and I really wish we would innovate more in terms of using palliative care in our field, but there's resistance to that.
A final few questions. How meaningful has something like sensible medicine been for you as a clinician? Because those are personal thoughts that you're sharing with the world. I do think they come from a vulnerable space, right? How fulfilling has that been for you? How meaningful has that been for you?
Yeah, so thanks for mentioning sensible medicine. I also keep my own personal Substack called Stop and Think. And I think I'm so glad you asked, because I'm very grateful for being able to write in journals, and I'm extremely grateful to Medscape for giving me a voice there. But journals and mainstream medical media is ad supported, is really advertisement supported ultimately. And our idea with Substack, and it's Substack now, but it might be something else in the years to come, is that my idea is that it's an independent, you're allowed to voice your opinion. It's not supported by advertisement. It's supported by subscribers. And I really see, there's a movement in journalism. Many journalists are going to this independent model, and I'm hopeful. I'm not for sure, but I'm hopeful that there may be a role for independent medical thinking, and that's the idea behind the Substack model right now. And it is extremely fulfilling to be able to write with more independence.
And has that been? To say that it's been impactful. Obviously, it has been impactful. That's the reason why. You do it, and you have a voice, and people would want to read what you have to write, and listen to what you have to say. Do you see this becoming more regular? Maybe not the right word, but what I'm trying to get at is, do you see yourself being more prolific when it comes to medical writing?
Well, we're never going to replace, New England Journal of Medicine and JACC, and we don't aim to. And we need medical journals to adjudicate science. But I hope that an independent medically thinking model of content, right? So it could be writing, it could be podcast, it could be video. That there'll be a role for that, and I'm glad that there is. And we've been at Sensible Medicine for a year, and we have a lot more subscribers than I thought we would have. We hope that it'll build into more people contributing. But just for your listeners, one of the things that I think builds success in medical writing and medical content is persistence. The podcast This Week in Cardiology in the first year or two probably had 30 listeners, and the thing that makes a podcast successful, or a place like Substack successful, and even medical media sites, is just persistence, and building on it. And nobody starts being able to write like Malcolm Gladwell. So it just takes time. And I learn as I go. One of the favorite things that I have on the podcast is now reader feedback. When I get good feedback and people tell me I'm wrong, I'm like, this is great content, because I can say, here's what I thought, here's what someone said, and here's what I think now. And that's been my whole life as a doctor, is just learning. I mean, the things, three of the most common procedures that I do today didn't even exist when I was in training. So persistence and learning and and an independent model is my hope. So we'll see.
Thank you for that. And any final thoughts for house staff, fellows in training, early career cardiologists, and listenership at large from you?
Yeah, I would say that I would 100% make the same choices and do this job again. I would recommend it. I have 2 children, neither went into medicine, but if they had asked me, I would have said, do this. It's a great field, and it sounds so banal to say, but it's a great field because we help people. People come in with sickness, and I always say this because it's a helpful reminder, but we are here to help, and we help people. We don't always succeed, but we're always trying. And whether we help them with meds or we help them with devices, or we help them even just with caring and being there, it's a great field. And I'm as enthusiastic now in after 26 years as I was when I started.
Yeah, no, Dr. Mandrola, thank you for your time. It's been a great conversation. Always great to connect and learn from you. And so good to see that you are as engaged as you ever have been, all through these years. And for those of you who are listening who want to share feedback on this episode, do write to us on Apple Podcasts, SoundCloud, or Spotify. This obviously will be shared across all social media platforms, including LinkedIn and Twitter. And if any of you have any feedback, either for me or for Dr. Mandrola, I promise you that we'll share the feedback with him. And he does with his sensible medicine writings or with his podcast, will get back to us with his response. So thank you again for listening, and until next Monday, have a good week, everyone.
Thank you.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app, or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.